Thank you to all those awaiting the start of the COVID-19 and Myeloma Ask the Expert webinar. We'll be starting shortly. Thank you. Good evening. Welcome to our first Digital Infoday Session. This webinar will focus on answering your questions about COVID-19. We've had a huge number of questions submitted and have tried to group these into topics. Don't worry if your question is not answered. We're going to try and cover as much as possible, but we'll be sending out a follow-up article with a summary of this session and answer any questions we didn't have time for. The webinar will be recorded and available to watch on our website from Monday. Just a bit of housekeeping. You can speak to each other and us on the chat function. If you'd like to submit a question, please use the Q&A function. Both these options are on the bar at the bottom of your screen. So I'd like to introduce this evening's expert panel. Our four top myeloma consultants from around the UK are Dr. Richard Souter from the Beatson West of Scotland Cancer Centre in Glasgow, Professor Jackson from the Freeman Hospital in Newcastle.
Hello.
Yeah. Dr. Karthik Ramasamy from the Churchill Hospital in Oxford.
Hi, Suzanne.
And Dr. Kerry Bygrave from the University Hospital of Wales in Cardiff. So I'd like to thank you all for joining us. I'd briefly like to tell you about Myeloma UK. We're a patient-focused charity. We're the only one of its kind in the UK dealing with myeloma and related conditions. Our funds go towards supporting myeloma patients, and we invest heavily in research with an eye on the end goal, which is finding a cure for myeloma. We receive no government funding and rely almost entirely on voluntary donations and fundraising from our amazing supporters. Okay, so now to move on to the questions. The first section of questions we're going to address are in relation to the risks and outcomes of COVID-19 to myeloma patients. We've had many questions about the level of risk the virus poses for patients and what happens if they contract the virus. So the first question from our audience is, what do we now know about the risks to myeloma patients with COVID-19? Are all patients at equal risk? Do those in remission or younger patients have a lesser risk? Can we start with you, Karthik?
Thank you, Suzanne. I think that's been one of the questions that's kind of frequently asked in clinical consults. Unfortunately, I'm going to start with the direct answer saying we don't know at this level of granular detail as to what the risk to an individual myeloma patient is and whether remission affects their risk. But I'm not going to stop there. I'm going to talk a little bit about a study that's been published. It's called the Open Safely study. You can Google it if you want. It's a study that's come out of Oxford. Ben Goldacre, one of my colleagues, has done this study. So Ben and his colleagues have basically gone on and looked at a population of 17.5 million people in the UK using a GP database. What they set out to find out is in this very broad population, who are the people, who are dying of myeloma, dying of COVID-19. So from 1st of February 2020, when the first case of COVID hit our shores, till the 25th of April is when this analysis was done. So that's important to bear in mind. Ben and his colleagues found there were 5,600 patients, people who died of COVID-19. In their 17.5 million, they had 860,000 people with solid tumors, and they had close to 100,000 people with blood cancers. And within the 100,000 people with blood cancers, what they identified was the risk of death with COVID-19 was almost 3.5-fold higher than a person without cancer. And this has been age and sex adjusted and adjusted for comorbidity. So clearly, this is an alarming finding. What is more concerning is people who have been diagnosed a year ago, which often means people are on active chemotherapy, tended to have a much higher risk of this 3.5-fold. And the risk fell down to about 2-fold if you were 5 years from diagnosis. Interestingly, if you were to compare that with solid tumors, the risk of dying from COVID-19 was only about 1.5-fold to people without cancer. There's some interesting points that's come out. It sounds like people with active hematological cancers, which means blood cancers, who are on active chemotherapy do have a very high risk. And unfortunately, I would definitely group myeloma patients within this category, and therefore I think the risk is high. We certainly don't know about the individual levels of risk, whether age matters within cancers and whether remission matters. We just don't have that data.
Thank you. Let's come in on that.
Yeah, I think one of the things we have to also is that there are the other risk factors, as you said, Karthik, and they have to be taken into account. So there is a differential risk. And if you are younger and fitter, even though you have a larger risk than the same population, you are still less likely to have problems than if you are older with other comorbidities. So all of those other factors do come into account, don't they?
I agree, Graham. I agree. Which makes it even more complex to individualize the risk for any single person. Absolutely, I agree.
Can I ask Karthik, because obviously we've all read about that BAME individuals at greater risk. Has that also been seen in myeloma patients, or has there just not been enough patients who've been infected? Does anyone know?
Because I think you've all frozen.
Sorry, repeat the question, Suzanne.
So obviously we've all read that people from BAME populations are at greater risk. Has that been reflected in the myeloma population, or have you sufficient numbers?
I don't think we have sufficient numbers for that particular population in our myeloma risk group. As Karthik said, alluded to the Oxford study, and as you know, Gordon Cook is also collecting data from the UK specifically around myeloma patients. But I don't think he yet has enough data to look at that particular risk factor. And obviously, I think we have to say to the patients out there, this is an evolving field, and we're working really hard to understand how this virus interacts with our population as quickly as we can.
So Graham, I mean, what's your view around sort of survival rates for myeloma patients who've been infected with COVID-19?
Again, Suzanne, I think that's a really interesting question, because during the height when things were really difficult and swabs were difficult to come by, the only patients we knew about were the ones who were poorly enough to come into hospital and were very sick. And so we kind of saw the worst side of things at that point. I personally know of many of my patients who've had very, very typical COVID-19 symptoms, but were not ill enough to come into hospital, so never got a swab. So I think the sort of population of myeloma patients we saw coming into hospital was a skewed one. And when we think we get more antibody testing, I think we'll discover that a number of our patients have had the virus and haven't been so poorly. And we don't have a handle on that. At the moment, we only have a handle on the poorliest patients.
So like you said, it's reassuring to know that there are quite a substantial number of patients who've not been too seriously affected.
Yeah, I think that's an important message. And of course, we want to protect our myeloma patients, and we don't know the full picture. But the part of the picture that we don't know is the number of patients who've had this without ever having to come into hospital. And I suspect there is a substantial group of those patients, even in our myeloma population.
I would just echo what Graham said, and we've certainly seen patients from all spectrums, from people who were asymptomatic, who we only swabbed because they needed to go to another hospital to have radiotherapy and they were found to be positive and completely well, to people that have unfortunately required a lot of oxygen and been under the chest team for their COVID-19, but actually recovered and gone home. So there is a range of presentations across the myeloma COVID spectrum, the same as there is across the non-myeloma spectrum as well.
Okay, thank you, Carrie. So if we can,
I was just going to say, Suzanne, there is a lot of work going on out there to try and work out individual risks, so it can be a bit more specific for individuals rather than just your, an age and that kind of thing. We have it in our medical profession where we score ourselves for risk now that wasn't there at the beginning. And one of the things I've tried to feed back about is there was a thing came up that perhaps oral chemotherapy was less toxic than intravenous, but of course I think it's really the immunosuppression, so I'm not certain that that's correct, and I've fed back about that. But I think as time goes on, there will be, as Cathy was saying, this word granularity to try and give folks a bit more detail about their specific risks as more information is collated both in the UK and from abroad. So hopefully will help people work out what is the risk of me going out of that front door.
Okay, that's great. Thank you, everyone. So if we can move on to the next question. So the next question is there anything specific myeloma patients should do if they think they have COVID-19? Carrie, can we go to you for that one?
Sure. So obviously they will have heard the advice and the news, etc., about what typical symptoms of COVID-19 can be. So those are things like a new and persistent cough, and that cough has to have lasted for more than an hour. It can't just be a one-off cough on a day that you didn't have a cough the day before. Also a new fever above 38 degrees C, and then a sudden loss of taste and smell. Those are the main alarm symptoms that are available currently to us. But actually what we found through clinical practice is that COVID can present in a whole variety of different ways. Some of them can be quite atypical. And actually what we're doing now is screening every single patient that comes into hospital for COVID. And that just gives you an understanding of how heterogeneously this disease can present. So we always say to our patients, you need to know who your key worker is, and you need to be in touch with your key worker. And they need to have access to your phone numbers, and you need to have access to theirs. More than ever at this time, those lines of communication need to be really strong. Ideally, I would hope that for the majority of you, that will be a myeloma CNS. I'm certainly very lucky to have one in my team and another assistant to her. If you don't have one locally, you should still have a key worker, and it's important to know who that is and have their contact details. Also, your inpatient ward, your hematology day unit should be able to give you phone numbers that you can get in touch if you're feeling unwell. That applies if you're on chemotherapy, but it also applies if you're not on chemotherapy and you're concerned. There should be people that you can talk to. So I think those would be my first recommendations, is to have really good lines of communication. And I'm sure everyone will now realize that the NHS is functioning, but it's not functioning in the same way that we did back in January. So our ability to suddenly review people face to face has been massively hit by this, because we're all being told to avoid face to face close contact if we can. But what it's really important that people don't forget is that doesn't mean that the NHS is not here for you, and that we're always on hand to give advice and see you if you need to be seen.
Okay, thank you. Does anyone else have anything they wish to add on that?
I think one of the things I would add to what Kerry said is that whilst we're discouraging unnecessary visits to hospital, we absolutely should reassure people that if they have to come to hospital, we are making sure we are practicing the safest medicine, the safest in terms of social distancing. All our clinically facing teams are all wearing PPE, and they won't be mixing with lots of COVID positive people. So I think that's an important message too.
Mm-hmm. Yeah, thank you, Graham.
Yeah, so I'm working clinically today. That's why I'm wearing my doctor's kit. Not something I did back in January, but that is the way our lives have changed. Our ward inpatient structure and the day unit now has green areas and amber areas. So green areas are ones where you have to have a negative swab before you can go there, and amber is one where your swab is pending. And we also have different teams that work in green areas and amber areas as well. So we've completely realigned our service, and the idea is to be able to provide as much contact for the people who need it in the safest possible way.
And is that the same for the rest of you? You've all got sort of like hot and cold centres?
Yeah,
I think
that's right.
yeah.
And it's trying to keep the patient safe. It's been trying to keep, that's the process. It's been since the outset, trying to make sure people don't get an infection that they could have avoided. It's sometimes very difficult, but yeah, that's how the system's managed. And there's, as Graham was saying, the supplies of PPE that were a big issue earlier on, or certainly in our experience, kind of resolved, so that when you go there, as you know, everybody's masked up. I think it's a lot safer. If you need to go in, you need to go in. I mean, that's happened within my household. It's scary, but if you mustn't stay at home if you're unwell. You have to get seek help, whether you're a patient or a doctor.
And I would add that there will be benefits from these changes that go beyond COVID. So every winter, there is an increase in respiratory viral infections. Flu, obviously, is the common one, but there's other ones that our patient group can be at risk of. And I think it will be nice to see some data in kind of months and years to come as to how all the measures that have been implemented to combat COVID actually have knock-on beneficial effects for us in infection control generally. And as we know, infection is such a huge problem in myeloma. I think that's actually something to feel positive about.
I would love to echo that, Kerry. One of the things we've noticed in our myeloma practice over the last 3 months is a big dip in all respiratory tract infections. And in fact, shielding has really reduced the number of patients who are coming in with other chest infections. It's been quite interesting to see.
And I also know my children haven't had a cold since March, and it's probably because they're barely going to school. So there's something in that as well.
Yeah. Okay, so if we could move on to the next section. So the next section of questions is in relation to treatments. So we've had lots of inquiries regarding when treatments will be able to go back to sort of normal. And there is a lot of understandable anxiety amongst patients, obviously you've seen that, who are keen for their treatments to resume. So the first question is around that. So when will all clinic appointments return to normal? It's a million-dollar question. What is the current situation? Richard, can you start with that one? Sorry, can everyone hear me?
I think Richard's frozen.
Yeah. Okay, can we? Yeah.
Do you want me to start?
Am I back again?
Oh, he's back.
Richard's back. Yeah. Welcome back, Richard.
Something was unstable, either me or the internet. I'm sorry about that. I don't think things are going to go back because we've got this physical distancing thing that is so absolutely critical, I think, in keeping our space. So in effect, we may have got the virus under control. In Scotland, there were 3 cases picked up today, compared with something like 500 in England, the last data I could see. So the virus is at a very low level, but the main protection is distance. So the clinic capacity has been absolutely slashed. So even though we've got the same number of doctors and we can do things remotely, we just can't physically get the same number of patients into any of our clinics or surgeries or operating theatres. So to keep it safe for everybody, this is going to have to carry on for a long term until we I guess we get the vaccine or the virus disappears. So the way we work is we're going to have to carry on with it. I think probably it works okay. There's been a huge amount of change, and I'm sure as a patient you'll notice that initially it's been phone call, so we've been trying to morph into the video calls, which are a bit better. You can see folks. So I think we are going to have to keep with this kind of distant medicine. And as we've been saying before, we're still here. When you need to come up, a change of treatment, something to be discussed, you can come up. Sure, everybody's doing the same, but there just isn't the physical capacity for the old style clinics of 30 people all jammed in on top of each other, for better or for worse. I don't know if that helps at all.
So what do you think are the biggest challenges regarding sort of like telephone clinics and video clinics? What's the limitations?
Well, from our point of view, the limitation the hospital's working hard at it is in the space of a couple of months, we're trying to change the entire IT system. So our PCs in the hospital are Windows 7, they don't work with a webcam, the Attend Anywhere works in Google Chrome, it doesn't apply for that. So basically, I can do it in the blood transfusion centre, but I can't do it in the hospital. So the video is going to need a huge amount of infrastructure put in, and people are working hard. All the clinic rooms now have a phone in them, they didn't have that in the past. So it's going to take time. So there's the physical bit, and then there's how you reorganize your day, because without doubt, how the clinic works, how people get their treatment, when they aren't there to physically pick it up, takes longer, and also that people are there. Now, when everybody was in shielding, the one thing you knew is when you phoned somebody, they were going to be at home. But as the shielding has relaxed, and I've noticed this, people are now out for walks, you phone them and they have the audacity to actually leave the house. So that requires going back to the telephone system being like the clinic system with an actual time, so that everybody knows when you're going to phone, because otherwise it's frustration. From the patient's point of view, you just get an answering machine. Hello, this is Professor Jackson, I didn't get you, I'll try again sometime. So these things are going to have to be formalized. Yeah. I mean, I'd like to echo what was said earlier on about how the things have changed, but the remarkable thing from my point of view of the shielding really is this striking reduction in other respiratory infections. I mean, usually during the spring, we're seeing lots of things like paraflu, background RSV, flu, and that has just completely disappeared. I mean, the quarantining has been remarkable, and not only getting the COVID down, but getting all the other infections down. And I have personally phoned patients or seen them in the video, and they look the best they've been for months. They look great, and I'm sure that's because folks have managed to keep infection free. So maybe not going out and up to the hospital is going to be good for people.
Mm-hmm. I mean, what's the sort of stem cell transplant sort of landscape like currently? Because obviously a number of people had those delayed, didn't they? Or Karthik, can you come in on that?
Yeah, obviously, I think I'd echo what Richard said, and I think Kerry said it earlier. I think a lot of changes that have been made, some of them are going to stay because we are definitely identifying some of them to be good. The only problem was we weren't prepared to deliver service in that way, and I think we now are, and I think we will be better able to deliver those services. The biggest area of concern, obviously, change-wise for myeloma patients was our ability to care for them with giving them the chemotherapy, which their consultant felt was the optimal thing to do. And those things had to be changed. And the guiding principle there was to keep people out of hospital. And that would mean, not giving something, everything has to be oral if possible. If not, when they come in, their visit has to be, limited to a certain period of time. So I think within that is where transplant came in, Suzanne, as you said. I think there's been a huge change in our ability to transplant for a number of reasons. One is obviously transplant is a process where you need to collect cells, and then you have to do a number of tests to make sure that they're fit, and then you have to bring them in. So all of this would involve a fair amount of coming and going into hospital, which puts people at risk. And the second thing is bring them into hospital, into a bed, means you need to be able to make sure that you have the capacity to do that. And the third is when you actually transplant myeloma patients, although we don't thankfully require ITU support for large proportion of our people, we need to have some amount of guaranteed ITU capacity for us to be able to do it. And unfortunately, that's where we kind of came short. And therefore, geographically across the country, a number of centers had to stop transplantation altogether. They had to really pick and choose who they needed to transplant based on risk and one-on-one discussions. And now what we have to do is to start discussing with patients again, look at our local capacity and gradually restart is what we have to do. So I think, optimizing therapy has been one area where there's been a significant change, and clearly that's something that we have to start to unpick now.
Okay, thank you. So if we can move on to our next question. What do we know about development of vaccine, and will it be suitable for all myeloma patients? Kerry, can you answer that one for us?
Yeah, sure. So obviously, obtaining an effective and widely available vaccine is a long-term goal in our fight against COVID. It's something that is taking place globally, and we hope that the UK will keep up with our European colleagues and other global colleagues in terms of that development and that investment, but that is something that is not necessarily in our hands. Obviously, those of you that have had a stem cell transplant in the past will know that you are revaccinated post-transplant. And the reason for that is that your immunity is lost as part of the transplant process. And your response to vaccination can be variable. So we would never discourage the myeloma population from having the COVID vaccine as and when one is available. We don't know for the population as a whole what the effectiveness rate is going to be like, and that kind of thing, and that will need to be assessed within our population too. But it's something that we hope will become, present on the horizon for 2021 and beyond.
Lovely. Would anyone else? Obviously, Karthik, one of the big vaccine groups is in Oxford. Is there anything? Did you have any insight into that one?
I quite like how Kerry started. It's a long-term goal. And I think that's the truth. I think we have to obviously manage people's expectations. I mean, we do have some peripheral contact with Sarah Gilbert and her group. And obviously the pressure is on them to deliver. But honestly, I think we have to wait for a period of time until such products are being made available. The question specifically about whether myeloma patients can get it, I think it's an interesting one, obviously, because as we all know, we don't recommend live vaccines for myeloma patients. That is one issue. The second issue is obviously a person with myeloma on active treatment may not necessarily mount a good immune response as another person who's not on active treatment. So I think that's an important point. So therefore, I think when vaccines do come out and all these studies are done, there may need to be other additional studies that need to be done to look at what vaccine responses look like in people who've had chemotherapy in general and also in myeloma population. So I think those sort of studies will happen, which is why, as Kerry said, I think it is going to be a long-term goal. But I don't think that all products that are going to be made available are only going to be for immune competent people, which means people who've never had chemotherapy. I think some of them would be made available to people with cancer or history of cancer. But how effective it is, we have to test it.
Yeah.
I think a word difference, though, even if it takes a while to get the vaccine to our patients, the fact that there might be a vaccine for the population will already start to protect them, because if you vaccinate the population, the level of virus will go down. So our patients will be protected even if they aren't the first group to get the vaccination.
Okay, thank you. So we're going to go.
And the other thing I would say, Suzanne, is
yeah.
everybody is naturally very, very focused on this kind of active immunization, what we're used to all the time, what we think of, what we get used to every year, the flu vaccine. But I mean, and that's going to take time. But to a little bit of hope for people, we've got to remember that one of the other things we can do is passive immunization. All right. So if you're pregnant and you've been exposed to chickenpox, you get zoster immune globulin. Many people may remember that. If you get bitten by a rabid dog, you can get rabies immune globulin. And what we may get before we get active immunization is much more data about whether passive immunization, the so-called convalescent plasma, which is a very non-specific way of giving passive immunization, works. And if that looks promising, and then that would lead on to sort of specific, potentially immune globulin, or even a specific immune protein, things that might be there as a form of a treatment if you do get infected. So just because that active immunization doesn't work doesn't mean that we won't get to passive immunization long before that, just to kind of before this winter. All right, because that's what everybody's worried about, with that really scary thing yesterday on the radio, that we may have passive therapy before the winter hits us. So not to be that not to think.
Oh, Roger's gone, but yeah, that was a good point. Yeah, I like that. So just to move on to our final topic, so it's actually about shielding. So as you can imagine, we received a large number of questions. Obviously, it's been very confusing for all of us, given the ever-changing advice and the guidelines. So obviously, with that advice differing around the country, I'm going to go to all panelists on that one. So Kerry, can we start with you on the Welsh landscape?
Yeah, so the latest Welsh Government advice is that shielding can end, quote, on the 15th of August. Already they have relaxed recommendations so that patients in Wales can go outside for exercise. I have to say that that's something I've been advocating for almost everybody all the way through. But it's not going for a run in Hyde Park with everybody on a Saturday morning. It's going for a walk late in the evening when the streets are quiet, just to get yourself some fresh air. And also that you're able to meet other members of another household outdoors. We're still obviously pushing physical distancing. I'm actually a big advocate of masks. I think too much in the case of COVID, we've looked very inwardly in the UK and we haven't looked at what's been happening in Europe. And if you spend any time in Germany and Italy and France and Spain at the moment, the population are wearing masks. And you just get on with it and then you try and get back to normal life. So I think there will come a time when we have to accept, it's a bit like seatbelts on a car or whatever, that that's something that can be helpful in certain situations. But that's the level of advice in Wales at the moment, is that shielding from the 15th of August can end. But as we said right at the beginning, I think it's going to be making individual assessments of your own need for shielding. And that won't just be based on having myeloma, that will be based on age. That will be based on other health problems like diabetes, high blood pressure, being overweight, those kind of things. And essentially, the more boxes you tick and the higher levels of community COVID that there are around at any one time, that will lead to a change in the suitability of an individual to go out and mix with other people. And if you score highly on all those risky things and there's too much COVID around, you shouldn't wait for someone to tell you to shield. You should take your own decision, and we're there to support you with that and explain why that's necessary. But that's something that I don't really think comes out of the messaging, because messages are just blanket, do this and hide, and that will mean that some people hide too much and some people hide too little.
Yeah, thank you, Kerry. What about Richard? What about in Scotland?
Yeah, well, it's been very interesting, particularly what Sarah was saying about the masks, because of course masks are from last weekend compulsory when you're out shopping. I know there's been a lot of kind of flurry about this in England. So until last weekend, there was a bit of kind of argy-bargy about whether somebody had a mask on or not. Then it came in and Nicola told us to put a mask on, and I have to say it happened that was it, overnight. Everybody put a mask or a face. It's a face covering, to be precise. So some people have got, I don't actually like the mask, can't see anything, specs steam up, so I put a shield on, and that's fine. And it went without any hassles at all. Like many of these things, just told that's what to do. No fuss. Everybody's got their face covering on, and it's gone okay. In Scotland, I think we're waiting for a guy called Professor Jason Leach to tell us what to do next. He's very keen in telling us exactly what to do down to the minutiae. But I think it's absolutely right. I think you do, and one of the tricky bits is knowing what's out there, because you do have to kind of think a little bit on your feet in this. I'm sure whether you're a patient or whether you're a clinician or anybody, it's sometimes difficult to know what's going on out there. It seems to be quite retrospective that we hear there's a problem in Leicester. It seems to be kind of 2 weeks after we know. So I think as a patient, or even just as a citizen, you've got to have a wee bit of your eyes and ears open to what's happening in your local community and find out what's going on for kind of balancing your risk. Hopefully, I think the supermarkets are keeping their support going, even if the food boxes have been great here by the Scottish Government. They've been really well appreciated by folks. But I think those kind of things, I'm sure people will keep going. I think keeping away from an indoor area, if you can avoid it, is very sensible. But I wouldn't worry about masks. I think they do work, and you can get a fairly cheap one online.
Yeah, thanks, Richard. What about You, Graham, and I think you've been advocating from the beginning that if it's quiet outside, you can go to the beach and up the mountain. Is that right?
Yeah, well, my adage in clinic, which I'm sure you know, is that, and I'm sure we'd all agree that if you have myeloma, or if you're at risk for any reason, you should treat everyone you meet as if they have the virus. Assume everyone has the virus and treat them accordingly. And if you do that, then you can go out, because you'll go out in the empty spaces. And I think one of the things that I'm sure that there may be questions about, but one of the things I've noticed is people's mental health has been difficult through this. And one of the things they've really struggled with is not getting out of the house. And you go out for a walk in an empty field where you don't meet someone, you are not going to get COVID-19 stat. It's not going to happen. So if you treat everyone you meet as if they have the virus, and I agree with Kerry and Richard, mask up, but go out and enjoy the fresh air. You're not going to get the virus from being up a mountain or by the sea, provided there's not lots of other people there.
So then that leads us on to the next question. Oh. Sorry, I've gone off. Sorry, I went off screen for a second. Sorry, everyone. And the next question was, should those who were shielding be using public transport or travelling? And that's both within the UK and further afield. So we had a patient who said they had a stem cell transplant at the end of February, planned to take a holiday in England with 5 friends. We'll be staying in a house with separate bedrooms, several bathrooms. The shared areas are large, and there's a garden. If the person observes social distancing when outside as much as possible, and as much as possible within the house, do you think they're being sensible and responsible going on holiday? Richard, do you have something to say to that one?
Well, I think that's right. I think it's what Graham says. It all depends about who the 5 people are that you're going with. Are these a group of people that you've been mixing with for the last few weeks, or are you exposing yourself to another five individuals? And it does require, I'm afraid, go back to this kind of thing. Where are the people from? I mean, it's just difficult to look. If you look, you can see graphs of where the incidence of the virus is. It tends to be higher in the UK in the big metropolitan areas. So if you're getting 5 people, I'm afraid, from Northumberland versus 5 people who are from some densely populated area in a bit of England, that is probably different. So I'm afraid it's difficult to give an exact thing. I think going on holiday is great. That sounds absolutely fine. You're out in the fresh air. It's absolutely zero risk. But it is that kind of indoor thing with that risk. And I think you just have to be careful who you're actually there with, because we don't know. We do know that a lot of people can be asymptomatic. So if these are people you've not seen for a long time, that's an issue. If it's critical family members you haven't seen for a long time, your life's misery without meeting up with them, that's probably different. But it is very difficult to give down to that specific kind of thing. As docs, we've been advised not to go abroad today on our holidays. I think it's unclear what flights are like. I mean, some people do, but that kind of air travel is obviously an issue. So I think it's difficult to say, but everybody needs their holidays. So it's that kind of balance. There'll be a whole winter ahead of us, but I think it's who you're with, and and then that kind of advice about the indoor areas and who you're mixing with. And I think the Scottish advice at the moment, if you're shielding, that you shouldn't really be mixing with other people indoors. Outdoors is fine, okay, but not indoors.
Yeah, Graham, can I ask you, what's your feeling about patients using public transport? Because obviously some patients need public transport to get to hospital appointments.
I think I would reiterate what Richard said. Obviously, if you're going to use public transport, I think one of the messages that we've slightly lost sight of because of everyone now focusing in on the masks is to remember your hands. Your hands are another way you can get the virus, and things you touch are going to be potentially able to transmit the virus to you. And the hand washing message seems to have disappeared. And I think we need to bring that back too. It's not just about masks, it's about washing the hands. And certainly if I were using public transport, I'd be very careful. I would distance, I would wear a mask, which you absolutely have to, but I'd also be aware of what you were touching and if you had to use public transport, to make sure you either had a hand sanitizer with you or you washed your hands regularly, and don't touch your face. And of course, wearing a mask is very good at stopping you from touching your face, which is another good reason for wearing them.
Yeah, I mean, I guess the thing is, I suspect you're all going to, I mean, you can put your thumbs up. Do you prefer hand washing to wearing gloves? Yeah, because I guess the downside is it's easy to feel more secure wearing gloves, but then you see people keeping gloves on for a long period of time and not realizing they need to sanitize their gloves and touching their faces with their gloves.
No one ever washes their gloves, but they are always washing their hands.
Yeah, that's a great message. Yeah, thank you for that. So then the last question, this is for, if you can start this one off, Karthik. Patients as well as their families may need to return to work or school. What steps should patients take to keep themselves safe?
Thank you, Suzanne. So I think I'm going to start with some very general message. I think the first thing we all have to realize is, when the shielding message came out, some of us doctors were kind of up in arms because we weren't ready to care for patients in a very shielded state. But that being said, does shielding work? Absolutely, it works. So therefore, what is different now, which makes us think that we don't have to shield? Well, what's different now is all the PPE that's available, the hand washing, the wearing mask stuff, that is important. The testing is widely available. I would like to think people's behaviors changed for good about how they look after themselves and personal hygiene, across the whole of the population. The infection rate is less. Hospital now has space to care for people if they were to come in with COVID-19. Depending upon even how unwell they are, we have the capability to do that. So I think that's what has changed. So there's a new backdrop right now we need to think about, and that's what has changed. So let's take this backdrop and then think through, as you said, families and needing to get back to work and school. So the places that people are getting back to should really be, COVID assessed, and as how hospitals have been assessed, workplaces have been assessed, schools have been assessed. There's a lot of stuff going out. Even my kids, although they love doing their kind of Google class from home, much to a lot of our annoyance, rather than going to school, despite me and my wife being care workers. I think they will have to get back to school, and they are going to be cared for properly in their school environment. So I think we need to assess the individual scenarios and see whether all of those measures have been taken and people feel whether that's safe or not. I do have a personal view that I think, like how people say, car accidents happen most often when you travel to your own home, purely because that's the route that you take often. So therefore, in the future, you're probably going to have a higher risk of getting COVID from your, near family members rather than from somebody in a shop or whatever, when the infection rates are low. So I think obviously you need to think through every single scenario and see if things are safe to do. We hope that with the testing rate and the test and trace system, we will be able to pick up small outbreaks. And obviously, if small outbreaks happen, then your behavior should change. You should not have a set behavior. Your behavior should change with what the local data is. And hopefully, people will be able to send this information to local councils more quickly than what had happened in Leicester. So I think that should help. So I think people should continually reassess their environment, their family requirements. But I do understand, I think for the physical health, mental health of people, I think normality has to resume in a certain way. And I think that should be enabled.
Okay, thank you, Karthik. Would anyone else like to come in on that?
I would totally echo everything that Karthik said. And I would also say, and again, this is a personal opinion, that unfortunately, COVID is not going anywhere. It will become less common and less prevalent, but it will still be around. And also the thing that I don't think you hear enough is that there is no such thing as a zero risk situation for many people. And a lot of the advice that we're given is not necessarily grounded in the science, although that's what we're always told. Often it's a best guess. And so it's always going to be about balancing your individual risk of being seriously unwell if you contracted COVID versus the risk of whatever the situation is giving you COVID. And that balance will shift in your myeloma journey, in your natural aging process, in your acquisition of comorbidities. And then, as we've already said, it will shift based on who you're with, what they're doing. But I also think getting back to normal life, getting kids in schools, allowing things like that that are so crucial has to happen. And we don't want relatives of myeloma patients to have unavoidable restrictions on them because of the situation. But I think you have to be honest and say we don't quite know what that's going to look like, and that's going to be something that needs to be continuously reassessed.
Okay, thank you. Does anyone else have anything on that one? No. And we've had a question that's come in live. So someone's written in, are there potential long-term effects from having treatment or delayed during the pandemic? Graham, can you answer that one?
Okay, I think that's one where we have to reassure our patients that any decision we've made to change treatment is taken with their safety in mind, but most of the changes will not impact on their treatment longer term. We've not taken any decisions that would reduce their chances of doing well with therapy. We've changed therapies, we've delayed transplants in some patients. But most of the things that have been altered have been balanced between putting the patients at risk of COVID versus making sure their treatment continues to the best of our ability. So I don't think there will be many or any long-term consequences of what we do for most of our patients. I absolutely don't. I think we've changed things with their long-term myeloma health in mind just as much as their current COVID risk in mind. And one of the things that have been made available is some drugs that we didn't have available previously that we've been allowed to use because of the pandemic, such as subcutaneous daratumumab, which reduces the time people in hospital. We've been allowed to use certain oral treatment regimes earlier in the treatment pathways because of the pandemic. So we've changed things, but I don't think patients' long-term myeloma health will suffer.
I mean, I guess one of the ones that obviously affects quite a lot of patients is having sort of the Zometa infusions paused. Is there anything you'd like to say about people who feel they've missed a few of those infusions?
Yeah, I think that they will not miss it. Zometa has a long half-life in the bones. Most of the people who are on long-term Zometa will not suffer at all from missing 1 or 2 doses, or even having the schedule change from 1 to 3 monthly. So I don't think they need worry. Anyone who needs Zometa acutely as a new presentation will get it appropriately. So I don't think anyone would have stopped or delayed a Zometa where they thought the patient was at risk from that.
Okay, thank you. Does anyone else have anything to add?
Suzanne, it was just to say, because I know this Zometa thing's come up a few times, there's quite a nasty bone disease called Paget's disease. This is not a trivial bone disease, and folks with that bone condition get their Zometa once a year. So that gives you some idea of the kind of long-term potency of Zometa, just to reassure folks. I mean, Paget's is not trivial. So I think that's it. It has been the changes, the drug changes induced by a crisis, like any major crisis, whether it's a war or a pandemic, have been remarkable, and it has actually expedited a huge number of treatments that I think we probably wanted for patients that could have taken years to bring through. So by regulation, so we don't know what the eventual outcome is, but it may actually end up being, oddly enough, better. But we've got to be quiet about that, or somebody will want to cost it all again.
Yeah. We've just got another question that's come in live saying, in view of the presence of COVID-19, what would be the best time, brackets month, to ask my GP for my annual flu vaccine this year?
Well, I'm sure the flu jabs are going to be, put out maybe even slightly earlier this year. I hope not for anyone to contact their GP. The GPs will probably going through the list right now, because one serious concern that people have for the winter coming up is if you have flu in full flow plus COVID-19 peak, I think that's going to be very bad. So I think, the flu vaccine, shots, I'm sure GP surgeries will reach out to all people. And again, I think if people want to give their GP surgeries a call, I'm sure they will entertain that type of discussion and then reassure them.
And then can I just quickly go around the screen? Do you have any final advice to patients? Richard, can we start with you?
I just thinking it's obviously a really scary time. It's been a scary time for us medics and nurses as well. We can see why it's very, very scary for the patients. But I think you've got to remember that we're seeing all of this at once because of this virus. But there have always been nasty respiratory viruses out there. If it's some way of consoling people, this thing makes it seem like it's some kind of thing that's come from outer space. But there are other nasty respiratory viruses out there. We've coped with them. They've always caused these kind of problems. And just to kind of reassure people that this isn't, although it's a pandemic, it's not something out of the ordinary. It's scary, but not out with what we can manage as human beings. I think we made huge advances in the last few months, how definitely getting that infection down. Hopefully we can keep it down and not to kind of lose hope. It can be, at times you can begin to get your head down, but I'm sure we will get through all of this. Vaccine or no vaccine, there's a lot out there. And just to kind of keep your head up, get out there, get the fresh air and stay positive. Yeah.
That's great. A nice positive message, Richard. Kerry, do you have some last words?
Only to echo what Richard said, that, everybody on this call has been through a tough time. There's been a lot of uncertainty. We've described some of the positives, some of the serendipitous progress that we've made through COVID, although all the losses and everything that people have suffered will not be returned, obviously. My final bit of advice is wear a mask, and also look for lots of reliable sources of advice. Look beyond the UK, look at Europe, look at countries like Italy where they've been really bad and got better, and potentially take your advice from other sources.
Okay, what about you, Graham?
I would obviously echo everything that my colleagues have already said. I would also say that the medical community and Myeloma UK and a number of organisations, everyone behind the scenes is working incredibly hard. We're on a massive learning curve. And I know I speak for Kerry, Karthik and Richard that everyone is really, really working hard to try and make things as good as we possibly can during the next few months. And people already have been doing some very positive things.
Okay, thank you. And finally, you, Karthik?
I think my final thoughts are, I think it has to be said, based on the initial in-period modeling, it has actually not been that bad. And it's not been that bad purely because we've all listened to what we should all be doing to try and get the death rates down. So I think it's important. I think that's a bit of good news. And every single change that has happened in how we as doctors behave or as patients behave or in the primary care, a lot of good things have come out of this, and we're going to learn from it, like how the reduction in chest infections and so on, generally has, so some good things are going to come out of this. It's not all bad. I think it's important to bear that in mind. As Graham said, I don't think people should be concerned about their treatment changes. These are short-term treatments, and every bit of detail was taken into account when doctors switched their treatments. And I think patients should start discussing with their doctors and nurses as to what best treatment to kind of stay on, moving forward. And the last thing that Graham said is, I think future is going to be better. We will have, better drugs to combat COVID. That could be an antibody or plasma, as Richard said, or vaccination. And what Graham said is a very important point. I'll echo that again. Herd immunity is gained by not just vaccinating myeloma patients. If everybody else is vaccinated around you, the non-cancer population, that helps cancer patients as well. So it's not all bad, but I recognize how tough it has been, and it could be tough for the next 6 months. But keep your head down, simple common sense, and we can all get through this.
Okay, that's great. Thank you very much. So we've now come to the end of our webinar. We hope that everyone who joined us today found it useful. Please visit our website if you'd like to watch this webinar again. We plan to continue running digital events, so keep an eye on our social media for announcements. Please remember we have our info line and Ask the Nurse service. as well as our COVID-19 Info Hub if you need further advice. Finally, I'd like to thank the panelists for giving up their time tonight and to thank you all for watching. Good night.
Good night.